Thank you. I've got a naturally quite loud voice anyway. I was doing a talk to some students and I started with a, "Can you hear me at the back?" Someone shouted back, "Mate, we can hear you next door." So if it's too loud, let me know. I'll try and keep a bit of a limit there. I mentioned to my mum I was coming up to talk at a conference a couple of weeks ago, and her immediate reaction was, "That's really short notice. I assume someone dropped out." But I think she's proud. Really. So can I ask how many paramedics there are in the room? So quite a number. That's fantastic. Thank you. And who else have you got? Doctors here? So not all on strike. That's great to see. Thank you. Nurses as well. Brilliant. Any others? No. Okay. Is there anyone else at all? Of course. Yes. Yes. Thank you. Yes. Most important of all. Thank you. Yeah. So it's really nice to talk to an audience of people who are all very passionate about resuscitation. So I'm very fortunate to work for Resuscitation Council UK. So we're based in London, but we're not an ivory tower that never leaves. As you can see, we do travel. I actually live down in Dorset. And when I got first asked, "Would you like to speak at SCAS23?" I thought, "Oh, fantastic. South Central Ambulance Service, that's right next door." But as my research supervisor would always remind me, don't just read the abstract, make sure you go into the detail before you agree to look at something. So I'm really excited to be here today, and I'm looking forward to chatting to you all later on as well. So I got asked by Gareth if I could talk about all of the science behind high quality resus, which is quite a big topic, I think, really. And he also said, "You only got 15 minutes, don't use too many slides and keep it light." So that's quite a tight, challenging brief to go through. But what I thought I wanted to do really was talk about what our individual roles are in terms of improving survival in out-of-hospital cardiac arrest. It's easy to read lots of research, get caught up in the detail, and then maybe feel that we can't, on an individual level, influence change, because it's such a huge system, isn't it? How can we, as individual practitioners, influence what we do, maybe beyond the individual patients that we go to? So I'm going to talk a bit about individualized care as well as guidelines. So often the guidelines are about evidence for an entire population or a very large sample, but we really need to make sure that we're treating the patient in front of us. So I think that's a thing that we'll come back to quite a lot today. This is where I started out. So 10th of January 2005, I started my basic ambulance aid course as a trainee ambulance technician back in Oxfordshire. And if you want to know what 19 years of Ginsters, pasties, coffees and late nights do, you can see the difference from the very naive and much leaner person stood at the back to the person standing in front of you now. But I've been on a journey I think probably many of you have been on in terms of our career, that we start out and you just accept what you're told. So as a technician, we were often told the difference between a technician and a paramedic was you could intubate and you could cannulate. And for many of you, that might resonate with when you did that transition on the old IHCD course from one to the other. It was about the skills. It was about the interventions you could do rather than the critical thinking. And I still remember the first cardiac arrest I went to as a very naive trainee technician with my paramedic crewmate. And it was to somebody who we probably shouldn't have resuscitated in the first place. He was in a care home in Oxfordshire, and hopefully today would have a respect form, would have some kind of care plan in place to stop that kind of decision making. We resuscitated them. We carried them down on a carry chair, still doing CPR, which we would never do today. We put them in the back of an ambulance, no Lucas, no auto pulse, no kind of mechanical CPR. And I expected the paramedic to go in the back and that I would drive, because that's kind of how we did it. But I'm not sure what the Scottish ambulance service is like, but in those days, Oxfordshire was quite unionised as well. And if you were attending half the shift, you were attending. There was no change, certainly for the individual I was working with. So he went to close the door as if to get in the driver's seat. And I was like, "But haven't you got to give this person drugs?" He said, "There's a big pile of them on the side. There's no evidence they do any good. Just give what you want," and shut the door behind me. Now, again, hopefully that would never happen today. We've moved on as a profession. Although to some extent he had a point, I think, in that we just got used to being very protocol driven. We weren't really sure about the evidence behind what we're doing, and things have moved on. But I do wonder what we may look back on in years to come and question whether we should have been doing what we're doing today. That's the nature of medicine and science, isn't it? That things move on and develop. And I wanted to share this. I've used this on a few talks about sort of the origins of resuscitation and where we came from. And a lot of this came from research into the drowned man, as they called it back in those days. And it sort of came out of the idea of how you could expel water from the lungs and resuscitate. Now, I believe this is a genuine video. It might actually come from a very niche website, but I believe it's genuine. And we might look at this and think, "Oh, isn't that quaint? Isn't that old-fashioned? And isn't it, frankly, slightly disturbing?" Yes, probably to all of those things. But initially, when I was asked to speak about the evidence behind resuscitation, this is where my mind went to. It went to okay, well, we know there have been studies about intubation and airway management. There have been studies about mechanical CPR, about the role of adrenaline. That's what we've all focused on in the last few years. And I can't possibly cover all of that in the time. One thing that I think really vexes us at RC UK, and I think probably all of you in the room, is that really survival rates haven't moved on. Despite all of these advances, all of this development of professional practice, still in the UK, in Europe, and in the wider world, we're really struggling to get good quality survival beyond about 10% of the population. Now, it varies from place to place, and we have periods where it goes up and down, but it's kind of stuck. And the frustrating thing is we know what to do to improve survival because there are excellent examples elsewhere in the world. We often quote Scandinavian countries, Seattle, Medic One, King County. We know what's possible. We need to stop describing the problem and doing something about it. But implementation is a massive challenge for all of us. And part of the problem is that nobody owns this. And we know that it extends beyond this, but for the interest of space, I'm just using the compressed version of it. So what do we at RC UK do about that? Well, you will know us for producing the clinical guidelines and also for advanced life support courses for the span of ages. So education, research, resuscitation is a huge part of what we do. But you saw in the previous talk, the alternative version of this that Charles Deacon produced with the much bigger circles showing the impact that earlier interventions have and where more work is needed. So we are very much also focusing on educating members of the public. So we have our Lifesaver product, which is an e-learning online tool, which will teach you 15 minutes how to do CPR, how to recognize cardiac arrest, what to do. Also covers choking. We've recently published a book called Aaron's Heart, which is about baby and child CPR, which you can order on our website. It's free of charge, just postage and packing are payable. We've influenced and lobbied for CPR in schools, which is now in the national curriculum. We're influencing Parliament as part of the All-Parliamentary Working Group on Public Access to Defibrillation. We're instrumental in Restart Heart Day, which is coming up later this month, and I'm sure many of you will be involved in that in this room. And also about promoting the circuit and registering AEDs nationally. So wherever we feel that there's a gap and we can influence and we can help, that's what we do as an organisation. So if you're part of RC UK, you can get involved with all of these things. There's lots of resources available on our website, and I will mention about what you can do to get involved as well. But I think it's important to understand from an evidence-based point of view, it's not just about the adrenaline, the intubation, the interventions. It's about the system we work in. And I understand that some of you were involved in you were having a resuscitation academy day this week, or that was something that was planned, I think, before. And the Resus Academy have a fantastic publication called 10 Steps to Improving Survival from Out-of-Hospital Cardiac Arrest. And that talks about the frame of survival as well as the chain of survival. So that's all the things that need to wrap around this chain of survival, to do with training, to do with having the right culture, the role of leadership, and the role of quality improvement. So I would urge you, if you haven't already looked at these resources, to have a look at the Resuscitation Academy guide and resources. And I'm going to talk a little bit about my experience of using that in another country, so and the impact that can have. So I'll come on to that in a moment. But before I do that, the original title of this was a bit about ABCs for paramedics. Now, there's a lot of very experienced, very expert people in this room. I probably can't tell you anything about what current evidence says about airway management or advanced interventions, because you may well know better than me. But I wanted to think about 3 things that we could all think about and reflect on that might help us implement evidence-based practice into what we do. The first thing is about avoiding dichotomous thinking. And I think Twitter or X or whatever it's currently called isn't always our friend in helping us with this, because sometimes we want to know a clear answer on something. Is intubation a good thing? Yes or no? Should I be giving adrenaline? Yes or no? Is mechanical CPR better? Yes or no? There is nuance in what we do. There is nuance in the guidelines even. And I think understanding the evidence behind it is really, really important. I said about don't just read the abstracts earlier. That's really important. I'll give you an example of that in a second as well. I would also urge you all to be part of the change that you want to see. If you want to influence part of the chain of survival, think about how you can do that beyond your current role. So if you're a paramedic that goes out and responds every day and does advanced life support, that's amazing, that's awesome. Is there more you could do in terms of teaching CPR to your local scout group? Could you go out and support a Restart Heart Day event? What else could you do that could actually influence it? And I know there's only so many hours in the week, but maybe have a think about what you can do around that. And I went to the World Parkinson's Congress earlier this year in Barcelona, and one of the sessions they talked about What's your superpower? So this is a congress aimed at carers, people with Parkinson's, researchers, scientists, all in the same room. We don't really have that with cardiac arrest and resuscitation. We don't always have survivors there. We do at the bigger ones. But what that really demonstrated was that actually all of us can make a difference. Whether you're a paramedic, whether you're a doctor, a nurse actively involved in resuscitation, whether you're just a community leader, all of us can do something in that chain. We don't have to leave it to one person. And the other problem is nobody owns the whole thing. Nobody looks after all of the chain of survival. In Scotland, in England, in Wales, we're all part of it, and there's a risk that we work in silos. So if you see a gap, you see an opportunity to influence it, we would absolutely encourage you to do that. And hopefully we've got some resources to share that can help you with that as well. And the third thing I wanted to say was that context is really, really important. So although a lot of the guidelines we produce, we talk about, well, they're either shockable or non-shockable, and everyone seems to fit into a neat box. We need to think about individualized care. So we need to think about the person in front of us. And in any given situation, intubation may be the right thing to do. Mechanical CPR may be beneficial in this situation for this individual. And it's important that we don't just think in binary terms of either it is or it isn't good. So how do we create our clinical guidelines? This is a question that we often get asked. So all of our guidelines come from ILCOR, the International Liaison Committee on Resuscitation. So it's a panel of experts filled with people from resuscitation councils and similar organizations across the world. And they will synthesize knowledge, do research, do systematic reviews, and that all goes into consensus statements. That will then fall down to the European Resuscitation Council, and then we will then create the UK ones based out of that. So I explained this to a colleague who basically said, so you've got another organization that does all your work for you, and then you put your stamp on it, which is kind of what happens, but we contextualize it for the UK, and we try and make sure that it's relevant for those of you who are undertaking resuscitation in this country. So to give you an example, if you're interested in where the evidence comes from, where the detail is, and you want to know, these consensus statements are really valuable. So I would point you to these ones that are produced from ILCOR if you want to go and you want to have a look. So rather than me stand up in front of you and go through all the detail of it, I would signpost you to look at this, because if you haven't read this document, it's not that long. It's really, really interesting, and it'll give you a real deep dive into where the evidence comes from and why things in the algorithm are the way they are. There's always evidence behind it. It might be weak evidence, but there's always evidence behind what we do. There are also some fantastic data sets you can access in the UK as well. So if you're a budding researcher, the Warwick Clinical Trials Unit and the ALV Hospital Cardiac Arrest Audit database is available to access. And there are other projects like the ERC database and Registry Eureka that regularly produces really interesting research. So we get emails in quite often to our office to ask very specific questions. So I'll give you an example. Somebody emailed us this week to say, should I be ventilating when I'm doing BLS? So can I have a quick show of hands? Who thinks you should be ventilating when you're doing BLS? Or is compression only CPR okay? So yes or no, what do we think? Compression only? Ventilation as well, what do we think? Okay, maybe half and half. A lot of people spotting the trick question thinking I'm not committing to this. I could say, what did I say earlier? What did I say about dichotomous questions? I've just asked one, haven't I? Yes or no, yes or no. Well, it depends, doesn't it? And that's really annoying in research papers. Anyone who writes an MSc, by the way, for the conclusion, you need to say, it depends and more research is needed. I've half written it for you, because that's always what you read, isn't it? But actually what this study demonstrated is that, I tell you what, I'll show you. What did this study say? Who's read this? Has anyone read this? A few people may have done, yeah, excellent. So if you have read it, you'll know exactly what it says. But let's say you've not read this before, you've done a bit of Googling, gone onto Google Scholar, I want to know the answer to this question. So what do? We read the abstract, don't we? Because we need to know, are we going to read this paper or not? So we read the abstract and it says, in this analysis, full CPR was associated with higher survival. If that's all you read, you cut and paste that onto X, send it off, there you go. Stop doing compression-only CPR. This paper's demonstrated that you need full CPR, you need ventilations as well. However, you carry on reading it, it suggests that guidelines should continue to emphasize the importance of compressions and ventilations during resuscitation, okay? So we're now thinking, compression only, no, that's very last year, let's get rid of that. But actually, is that really true? No, what they found, and if you actually delve into the full text of the paper and the conclusion, it will say to you that the results were that teaching chest compressions with ventilations is preferred in certain settings. And if you think about what we've already said this morning, some CPR is better than no CPR at all. Ventilations to some people are a barrier to them doing any kind of resuscitation at all. So if we just boil it down to that dichotomous question of is it better one or the other? Well, it depends. It depends on the context. If we're teaching people, lay people, to do CPR, I'd much rather they just did compressions. And the detailed study actually says at the end there, it can be a bridge. Compression only buys you time. If you're a healthcare professional turning out, yes, we'd like you to ventilate as well, because the evidence suggests that that's beneficial and that it's associated with increased survival. But no compression at all is definitely associated with worse outcomes. So there is nuance to all of these questions. It's really, really hard just to give a yes or no answer. So we need to be careful to understand the evidence behind it. I know there's tons out there and you can't read all of it, but these synthesis documents, these ill-course statements are really useful at answering those questions and helping you as individuals make decisions. Your neighbour asks you to teach you CPR, what do? They don't want to do mouth-to-mouth. Fine, teach them compression only. If you're teaching it on your ambulance station to your colleagues, yeah, we think BLS with ventilations is a good thing. So I spoke earlier about the Resuscitation Academy and the 10 steps to improving survival. And I want to give you a very brief example of where you can apply that in practice. And I say you, I mean anybody in this room, because I'm nobody special. But as a paramedic, I got involved with a quality improvement project in Lebanon. And I lived in Beirut for 18 months and worked directly with the Lebanese Red Cross. And I worked with Jerry Overton, actually, who sat here today. And I met him first, I think, in a Starbucks in Beirut somewhere randomly. And he was very involved in supporting their dispatch process. And I know he's going to talk a bit about the role of that later on today. So in Lebanon, the emergency medical service, the ambulance service, is run by the Red Cross, the local Red Cross. They're not the International Committee of the Red Cross, but the local Red Cross Society. And the reason is they've got complete access everywhere. They're very respected, very trusted. They're run entirely by volunteers. And because of the complex political and other history there, it would be impossible to have a government-run service there. Even if you could fund it, it would be really difficult to do. So I said, context is everything. So we went there, spoke to their director, and they said, we want to improve survival from cardiac arrest, among other things. How do we do that? So we went through the 10-step survival. We looked at the Resuscitation Academy guidelines for this. There are a whole load of different things that you can do around increasing access to public access defibrillators, around making sure people are trained to do bystander CPR, having a really functional dispatch system. There's a toolkit that you can follow at a system level. Many of you won't ever be involved in looking at it at a system level, but then you absolutely could be as well. And I'll come on to explain in a minute how I got involved with this. But one of the key things we did with these volunteers who give up huge amounts of their time is to focus on what matters for them there and what they're capable of doing with the resources and the skill set they have. So I met a load of people who said to me there, all we need is ALS. We need to be giving adrenaline. We need to train them to do IV access. They should be intubating. They said, what are you doing at the moment? I said, we're trying to stop everybody intubating, giving adrenaline, just sticking IVs into people. We're trying to focus on the things that matter. We're trying to shift back to focus on BLS rather than just desperate to get to ALS all the time. And I think we've probably done that in the UK now. We're much better focused and driven by the evidence. So that's exactly what they did. And they have a 3 shock and move strategy there, based on the idea that if you are in a shockable rhythm, if you are going to be defibrillated successfully, the survival rate tends to fall off after 3 shocks and refractory VF, and you need to be transported and treated at that point. But they'll give it a go. And if you have a cardiac arrest in Beirut and they come out to you, you will get absolutely awesome basic life support delivered to you. And there's every chance that you will survive from it, given how quickly their response time is, particularly in the urban areas. There are attempts to try and set up a registry with a hospital. There's lots of other things that are involved there to do that. But for the paramedics in the room thinking, well, I'm never going to get involved in anything like that, I would say the same. I thought exactly the same. Now, this came off back in 2014. I decided to do something a bit different. So I volunteered with the King's Global Health Foundation. I went to Sierra Leone for 3 months, worked at a hospital, did some trauma training with the nurses. Towards the end of my time there, I met a very nice young lady who worked for the World Bank. She then moved to Lebanon. I met her very briefly right at the end of the time there, and she said, come visit me. And I thought, oh, this is pretty cool, jet-setting lifestyle paramedic. Yeah, I'll do that. However, when I went over and visit her, she'd sobered up quite considerably from when she first met me. Took one look at me and thought, I don't really want to spend any time with this guy. And I didn't see her the whole week. She just disappeared. So I'm in Beirut on my own. I don't know anybody, thinking this was a bit of a bad call, feeling a bit sorry for myself. Like, what can I do? I'm sure you've all been in a similar situation. So I got in touch with someone from the Red Cross locally. I think it was through LinkedIn randomly. And I said, can I just come and do an observer shift or come and see what's going on there? And I went to Jumeirah to 102 station in West Beirut, and I spent the night with them. We spent up the whole night talking, chatting. went to see their director, and then afterwards, and he said, well, we need a bit of consultancy work done. Would you like to come back, do a service evaluation with us? Because we've been looking for somebody like you, but we've no idea how to find a paramedic who's used to doing this sort of, work, doing ALS or doing resuscitation. So we'd like your help. So I went back, did that. One thing led to another. And before I knew it, there's a consultancy project going. It took a few years to get there. And I moved there for 18 months and was part of this amazing project. Okay, so in terms of sort of chain of survival, we talked about what could you add on. So I think Michael's tragic dating history hasn't appeared on any chain of survival anywhere. But actually, fortuitously, sometimes you never know where these things are going to lead. So I would encourage you, if you are a provider who's interested in getting involved with other things, put yourself out there. Maybe not quite like that, because that wasn't particularly enjoyable initially, but you never know where things might lead. And I've had the pleasure to work with the Red Cross on a number of occasions since, in Iraq, in the occupied Palestinian territory, went to Ukraine last year as part of their rapid deployment team. They're an amazing organization, but they need people like you, people in this room who are experienced practitioners, who understand chain of survival, who understand resuscitation, who understand how these things work. And there's no reason why anyone else can't do something like this. So I'd actively encourage any of you who think I'm too small to make a difference. I admit this is perhaps a little bit extreme for some, but yeah, absolutely, you can get involved. You can make a difference. You can influence survival and get involved, whether it's in your local community or even play a small part in a big project in a country somewhere like that. It's all to do. And if you work in the NHS, you've got an amazing skill set to do that. So I'm going to finish then by saying, if you do want to get involved more locally, please go to our website, because you can sign up there to be a member of the Resource Council. You can get emails from us, you can get research updates, you can click on Get Involved button, it will tell you what to do. But thank you very much for your time today.